All right, welcome everybody. Thanks for taking some time out of your GI ASCO, and thanks to our faculty, particularly Dr. Strickler, who is making a last-minute fill-in, which I'll get to. But welcome to this program, which is Expert Second Opinion, Current and Future Roles of Immunotherapy and Targeted Therapy in Gastroesophageal Cancers. I'm Sam Klempner. I'm from Mass General in Boston, and I'll be moderating this. These are our faculty. Dr. Rutika Mehta from Weill Cornell, Dr. Ajani from MD Anderson, and Dr. Strickler from Duke. Here are our disclosures. I'll just go through this quickly. All of these are also available in the slides that you guys have access to. This program is being supported by educational grants from Astellas, B1, Gilead, and Jazz. And the CME Planning Committee members, as well, you can see down there, are all independent, so they do not have any relevant conflicts. This is an educational activity, but it will contain discussion of non-FDA-approved uses for agents and regimens, and so obviously please refer to the official prescribing information and label for each product and the approved indication. All right, let's get this program going. Again, you're in the right side of the room here for talking about gastric and esophageal cancers. And here's our agenda. So we're going to start off with Dr. Ajani talking about HER2-targeted approaches in gastroesophageal cancers. And we'll move over to Dr. Strickler talking about Claudin 18.2, followed by Dr. Mehta talking about immunotherapy. And then I will close the program at the very end talking about novel agents under investigation. This is started out with a survey. Many of you may have completed this, just so you understand where some of this data and some of the questions are coming from. So this is a very recent. This was just done over the last week, essentially. So let's jump right in. I will turn this over to Jaffer to tell us about HER2-targeted approaches.
Thank you, Sam. Good evening, everyone. I'm very honored to be presenting here today. I want to thank RTP for inviting me. So I'm going to focus on HER2 landscape, but particularly zanidatamab, because that's the new kid on the block. And we'll be talking mainly about frontline treatment. I'll mention a little bit about second line, but we're not going to be able to cover all the early development programs, so there are so many of them targeting HER2. So that's exciting. So first, a few moments on zanidatamab. It's a very unique molecule. It's an asymmetrical antibody that is bispecific but is paratopic. Paratopic means both arms of the antibody will attach to same TAA, or tumor-associated antigen. In this case, it's HER2. So as you can see from this diagram, it's attaching to one receptor at domain 4. This is domain 2, and then another receptor at domain 4, very close to the membrane. And if you just imagine, thousands of these antibodies are engaging two receptors. So you got crowding of the HER2 receptors, and the FC portion, this portion here is sticking out. So in the trans position, which means the antibody can engage two receptors, it will form a cluster and then make a larger clump, and that is called a cap. And then there is hexamerization, like a hexamer structure, and I'll explain what that can do. So here's the basic experiment where you can see zanidatamab forming these caps, and they disappear within 15 minutes. So it's internalized, rapid internalization. It doesn't happen with other trastuzumab, pertuzumab, or even combination of pertuzumab. So you just wonder what these caps can do. So this is just a cartoon of the cap, where all these HER2 receptors are engaged by zanidatamab, and the FC portion is sticking out, which will allow this C1q to engage all the FC receptor. It needs 6 of them. And by doing that, it will trigger complement-associated cytotoxicity, CDC, and that is very unique to zanidatamab. It cannot be done by trastuzumab, pertuzumab, etc. So there are 2 different ways of assessing this clustering. And here you have zanidatamab, trastuzumab, pertuzumab, and combination. And you can see these big clumps that are formed by zanidatamab. And this is called clustering. Highly immunogenic, will alert the immune cells. And then when there is hexamerization, this C1q will come, and then it will attract C3 components of the complement system, and then start the CDC. So zanidatamab can cause all 3 methods of immune engagement, and this is ADCC, this is phagocytosis, and this is complement. So I'm not going to read all this to you because you will have the slides. So there are multiple very unique features of zanidatamab. So just to go over some of the experience, because I've been involved in development of zanidatamab from very early on. And this was the phase 1 trial that was led by Dr. Funda Merrick at MD Anderson. And I co-managed so many patients. And these were HER2-positive patients, but in the 5th and 6th and 7th line. And what we noted, this will be hard for you to see, that single-agent zanidatamab in 5th and 6th line resulted in 30% response rate with a durable response that we didn't see with chemotherapy. So there was obviously immune engagement when you get very prolonged duration of response, or even non-response like stable disease for very, very long time. That means immune system is engaged. And these are the waterfall plots. You won't be able to see in detail the GEA patients, but there were several of my patients that did extraordinarily well that we were all surprised. This was followed by a second study with zanidatamab combined with different chemotherapeutic combinations. And this was the prelude to Horizon 301 study that you probably saw the results in the meeting. But this study formed the basis for how to design the combination for phase 3. And here also we saw a lot of responses, were totally unexpected to see. I know there is chemotherapy here, this is first line. And then many of them were durable. I have patients right now getting zanidatamab for 4 years and 5 years in complete response. Here also we saw progression-free survival that were not reported. So limitation of this data are that this is first line, this is a single-arm study. So that brings me to show you the Horizon GEA-01 data. And this was a 3-arm study with 2 arms, B and C being the experimental arms, and A is the control arm. At this time, there was no PD-L1 information, so there was no immunotherapy in the control arm. And there was a hierarchical analysis of the data, so PFS first, OS later. And these were the 3 subgroups with demographics, close to 300 patients in each arm. And so this is the largest HER2-directed data set there is in the first-line setting. And I know this will be hard for you to see, but there were 30% of patients were PD-L1 negative, and as I mentioned, there was no PD-L1 selection in this trial because we didn't know anything about PD-L1 when this trial was conceived. So this is a comparison between the control arm, trastuzumab plus chemo, versus zanidatamab plus chemo. So this is a pure comparison of trastuzumab versus zani. And you can see a tremendous benefit with a progression-free survival of 12.4 months. That has never been reported in a randomized trial. When we look at the arm A control versus arm C, which has tislelizumab, the numbers are better. So what you can do is flip back to the previous slide and look at the numbers at different landmarks. You will see the numbers are better by 7-8%. That is the effect of tislelizumab. And here also you can see majority of the time the treatment is favored for the experimental arms, B and C. So this is survival data between control arm and zanidatamab chemotherapy. This has not reached statistical significance. This is the first of 3 analyses that will be performed. But when we compare the control arm to triplet, zani, tisle, and chemo, the hazard ratio is 0.72, which has never been reported such a low hazard ratio in frontline setting, and highly statistically significant survival of 26.4 months. The previous benchmark is 20 months. So when we look at the landscape of phase 3 trials that are reported, I just want to point out the control arms. With TOGA, it was 11 months. With the Keynote 811, was 16 months. And with Horizon is 19 months. These are control arms. So our patients are doing better, probably because of second-line treatment, probably because of better care that we can provide. But we'll look at the experimental arm. It's 13 months, 20 months, 26 months. And PFS also is increasing. So you can look at this more carefully later on. Finally, I want to show you the gastric Destiny Gastric 01 trial that had less than 200 patients. But just keep in mind, take a picture in your mind about the space between the 2 curves. So this is the first phase 2 randomized study that led to approval of T-DXd. This was followed by a phase 3 trial, and this is the interim analysis. But look at this space between the curves. It had narrowed considerably. So we don't understand why, but phase 3 results are not as good as phase 2 results. But they're still statistically significant. So we're going to skip this one, and you can look at this later. So in conclusion, the HER2 space is evolving rapidly, and which is really good for our patients. Zani is better than trastuzumab. We didn't have time. Today we don't have time to talk about zani-induced toxicities, but these are manageable, and one has to be very aware. Tislelizumab definitely has a contribution, and T-DXd is solidly positioned in second-line therapy. So always remember to consider that. You have to select patients properly. And there are 3 phase 3 trials that are going on. This is Gastric 05, not 01, then Artemide, and the HLX Gastric 01 trial. So if we have chance, we can discuss that. Thank you very much.
Awesome. Thank you, Jaffer. You are exactly on time, and that is perfect. Now I'm going to start by asking you the question that you've probably been asked in some form multiple times at this meeting, which is, you've got this case, in this case, a young patient with metastatic gastric cancer, HER2 positive, also PD-L1 positive with a CPS score of 2. And you just presented the Horizon GEA, so if all of this stuff was available to you right now, what would you do clinically?
Yes, so, I'll make sure that the patient can tolerate the IO, and I'll give all 3 drugs, or all 3 components. So it will be zanidatamab, tislelizumab and chemotherapy. There's no reason to consider pembro or nivo, because today, when I have a HER2-positive patient, I use Keynote 811, and I don't, instead of pembro, I'm not looking for nivo or tislelizumab. So in the Horizon trial, why should I substitute tislelizumab to any other?
Yeah, I think this is probably one of the more important questions of the whole thing and what many people are wondering about given the positive phase 3. And John, you've done tons of HER2 agents. You've done tucatinib. You've participated in this. So what is your sort of top-line impression of the data, and what would you do if this was available to you?
So I think that's the key statement. What if it were actually available to me? And that can be a challenge sometimes with novel therapies to be able to access them in the clinic. I think we need to stick with what we know from Horizon GEA-01. What we know with near certainty is that zanidatamab is superior to trastuzumab. Okay, there are still some gaps in our knowledge because the control arm was not a modern control arm in that it was not a Keynote 811 backbone. But I feel like based on the evidence, zanidatamab belongs in the treatment algorithm for a patient with HER2-positive metastatic gastroesophageal cancer. What is also intriguing about this data, and what surprises me in a way, is how little PD-L1 status seemed to matter with zanidatamab in Horizon GEA-01. And that one is tough to figure out. And in the back of my mind, I enjoyed, Jaffer, your talk, because I do wonder if it's novel mechanism of action, the different ways it's causing cytotoxicity, which appear to be immune-mediated, maybe that is potentially a mechanistic explanation for why PD-L1 status doesn't matter for zanidatamab, where it does matter for trastuzumab. And I'm curious if is that what your interpretation of that data is?
So I don't think we have a very good answer.
Right.
But data certainly support the use of zanidatamab in PD-L1 negative versus positive. Till we digest this and discuss among ourselves several times, I think currently I would just follow the data.
And Rutika, what about you? You're obviously on these papers. You have experience clinically with Zani. What about your sort of top line? You feel the same as Jaffer and John?
I concur with Jaffer and John. I think this is practice changing for sure. Zani is way superior than trastuzumab. There's no doubt about it. I know Jaffer didn't have a chance to touch upon toxicities due to time limitations, but I think diarrhea is a significant toxicity, but probably manageable with the chemo backbone that we would plan to use.
Yeah, John, comment.
I think it's very important to emphasize the toxicity component because especially when we bring a new drug into the clinic, there's always a learning curve. And the key thing that I've really zeroed in on is we know that zanidatamab increases rates of diarrhea. However, through that phase 2 open label experience, they learned how to very successfully manage that in a way that preserved the activity of zanidatamab and improved the tolerability. And specifically in cycle 1, the first 7 days of cycle 1, there's mandatory loperamide twice a day for 7 days. And with that intervention, interestingly, although diarrhea was common in the zanidatamab arms of Horizon GEA, it did not appear to lead to treatment discontinuation of Zani. And I do think it's because that diarrhea is front-loaded in that first cycle, and it's because they did institute that measure in that study. So something very important for all of us to keep in mind as we bring this into the clinic.
Yeah, I totally agree. I mean, implementation of this is going to require a little bit of a learning curve, but diarrhea is something that I think as oncologists we all have familiarity with managing, as well as nausea and other common symptoms.
Right.
Jaffer, I'm going to come back to you on this second case because you mentioned 811. So a little bit atypical here, also a younger patient with advanced HER2 positive, PD-L1 positive disease. Prior to coming to a new practice, got FLOT times 3 with looks like doesn't get any biologics with the FLOT and had stable disease, maybe a little bit unusual not to have any response. Transition to a new practice. In this scenario, in the current day, with what you have available to you right now, would you continue the FLOT backbone, or would you migrate more towards traditional 811?
Yeah. So I would never use FLOT in metastatic setting. And I know there was a study comparing FLOT-like regimen to FOLFOX, and FLOT-like regimen was a little bit better. The hazard ratio was about 0.8. The advantage was very minor. The toxicity is much more. So metastatic patients are more symptomatic than localized patients, and they're more deficient in nourishment. So I would stay away from FLOT. In this case, if this patient came to me with those biomarkers, again, I'll make sure that they can handle Pembro, and I'll just use Keynote regimen.
Yeah, I agree. I think if you've got active biologic agent like this, the additional benefit of a taxane in this scenario is probably quite limited. Rutika, just real quickly, your thoughts as well?
Yeah, I agree. I would never do FLOT in this situation unless and until there was a curative intent treatment planned for this patient and you have finite treatment cycles planned for this patient. I would use FOLFOX backbone with Pembro and trastuzumab.
All right, let's get to a couple more cases because we've got a bunch and then some good questions that have come in. So now you've got a little bit other end of the age spectrum. You've got an 80 and 87-year-old patient here. HER2-positive patient, a lot of liver mets. We see that pattern in HER2-positive patients periodically, nodes and liver. Clearly is symptomatic from their cancer, weight loss, poor performance status. What are you doing in this first-line scenario, John? You also brought up, sort of the importance of managing toxicity. So someone who's maybe a little bit more borderline.
Yeah, this is the art of medicine, not the science, right? And we'll never have a trial where we can randomize 500 patients to either arm and answer this question. I think the question for me is, what can this patient handle? What's the patient's goals, right? So an 80-year-old clearly is, so deconditioned by her illness that she may be on the verge of being admitted. So I think it's, first of all, just starting with a frank discussion about what that patient's goals are, what are their sources of support. If we give an aggressive treatment, do we have support around from other family members, neighbors? So if the patient is wanting to be as aggressive as possible, what we've got here are some actual biomarkers. When I see HER2 positive, I'm hoping it's IHC3+. Assuming it's PD-L1 positive, I think the first question is, could this patient take, is the heart function good enough to take trastuzumab, right? Or even a Zani, but I think, assuming access is limited, it might be trastuzumab. And then you would love to get in a situation where you could potentially give Pembro and add that in, right? And then the question is, what cytotoxic could you put on top? And I might start with a chemo-free and just kind of slowly layer in the cytotoxics. If that patient's performance status improves as I'm layering on those treatment, that's telling me that performance status is limited due to disease, right? So the more I can kind of take away and kind of eat away at that disease, the better that person will feel. But if that performance status is low due to baseline comorbidities, I'm not going to make that person feel better or live longer by giving FOLFOX with trastuzumab and Pembro. So, yeah, that's why I say it's an art of medicine, not a science.
Yeah, I agree. I think, the biologic-only lead-in is interesting. We saw an older phase 2 from Dr. Janjigian looking at this, and they had a few patients that did this approach, and it was like a third of patients that had some response even after just the biologic doublet.
Right.
Rutika, I'm going to come to you. So sort of same question, spinning it, but let's say a patient is a little bit fitter, maybe like the second case. We've seen data on empiric dose reductions in older or more frail patients from this old go-to randomized trial in elderly or frail with CAPOX. What kind of FOLFOX dosing do you do or think about? Talk about the bolus, your platinum, and 5-FU kind of dosing.
So my chemotherapy backbone is typically FOLFOX, and I universally don't do 5-FU bolus in metastatic settings. If I have a patient probably older than 75, I'm typically reducing the dose of oxaliplatin to about 65 milligram per meter square rather than 85 milligram per meter square. Unless and until they're extremely fit, they're kind of walking like a 50-year-old, that would be a different aspect. But that's typically my FOLFOX dosing for majority of the patients. that are elderly. In the second case that you have here, looks like the patient did not receive oxaliplatin, just 5-FU, pembro, and trastuzumab with borderline functional status. Borderline could have different implications, but if we're talking about, like in the first case, bordering on ECOG of 3, then again, goals of care discussion is warranted here, because clearly the patient was not even fit enough to get oxaliplatin in the first-line setting. I would probably have a goals of care discussion.
And Jaffer, so similar questions to you about your sort of FOLFOX dosing, but let's take the second case a bit, and 2 questions. So let's say this person is still fit. Are you going to biopsy them at the time of progression? You know, in the original DG01, it wasn't needed, and the label doesn't require it, but it recommends it. And in DG04, we saw that everybody required to have a biopsy before going on TDXD. So maybe if you don't mind commenting on the case like that.
So I think, it's hard to answer when you have description like this on paper, because you really have to see the patient. Already progressed on first-line treatment. So I would, it's FDA also recommends repeating HER2 status, but I wouldn't consider this, unless the primary is in place and there's another reason to do an endoscopy, etc. Might do a liquid biopsy, but whether to treat with TDXD will be a very difficult question to answer for this patient with this age. So you could consider just single agent taxane or irinotecan, or have a long discussion and see if they just want supportive care.
Yeah. And then real quickly for all of you, and then we'll go to the next cases. Let's say Zani was available to you now also. Would you have concerns about both of these patients? Would you say, hey, it's our best drug, we're going to give it because response is going to be important? So, Rutika, you can get first crack quickly. If Zani were available to you, kind of yes, no for both cases.
Yeah, if I'm a purist and a clinical trialist, PS of 2 or more were not included in the trial, I would probably hold off on treating them with Zani at this time, unless more experience is gained by treating other patients with Zani and kind of trying to understand the nuances of how to manage these side effects. I would not be comfortable offering Zani tomorrow to these 2 patients.
And John, same questions to you, and then Jaffer.
For the first patient, that's not the first patient I would ever treat in my clinic with Zani. Okay, maybe the 5th, but not the first. I think while Zani is clearly more active than trastuzumab, it does have greater rates of diarrhea and GI toxicity, and you just want to make sure that person has adequate support around to handle dehydration. Someone will call the office, make sure she comes in for fluids. So yeah, I'd like to get a little more experience with the drug before I start doing it in those scenarios. For me, the 87-year-old male case in the second-line setting brings up all kinds of interesting questions because, clearly I would not give Zani in that case because now we're in the second line. But the question is, what's the role for TDXD here and rebiopsy? I think there has been some very interesting work done out of Japan showing that in these elderly and frail patients, that approved dose of 6.4 mg per kg is not necessary in this group of patients, that a lower dose is probably not sacrificing much in the way of activity and is likely better tolerated. So I would think about maybe a circulating tumor DNA to confirm HER2 amplification in blood, and if I gave TDXD, it would be at that lower dose in that particular scenario.
Jaffer,
yeah.
You can comment, but maybe for the sake of time, we'll just go to the next one.
Yeah.
I actually have a practical question for you all. Let's say Zani is available to you, and John, you mentioned the 7-day lead-in of scheduled Imodium, but do you envision sort of in your practice having someone call the patient on day 8 and check in? Because could you not extend the Imodium if they were having diarrhea, for example? How are you going to formally structure this? And Jaffer, I'll start with you.
Yeah, so I wanted to mention that Zani, as a single agent, the rate of diarrhea is very low. Also with taxane, it's very low. And the study that I showed, the first study that I showed, this was the scenario there. Patient already had trastuzumab treatment, and then they got Zani and got about 30% response rate. So having said all that, I would still like to see the patient before you give the next treatment. Yeah.
Awesome. And then this is something I think we all encounter. So this is essentially a case of someone who has really no visceral metastases, but some non-regional lymph nodes, where technically by the TNM criteria, this would be a 4A or 4 patient, so they are stage 4, but this is an otherwise fit 52-year-old, highly HER2 positive, highly PD-L1 positive, interested in pursuing aggressive strategies even outside sort of the standards of care. And Rutika, I'll let you start off with this case. Like, how would you approach someone? You've got 2 good biomarkers, it's technically a stage 4 patient. We do have these patients out there.
Yeah, I think it's GE junction adenocarcinoma. I would, if we're looking at a curative intent treatment for this individual, then I would have the patient meet with the surgeon, probably also do a staging laparoscopy to see if they have peritoneal disease. But as you mentioned, this is a clinical stage 4 disease. I would vote on doing biomarker-driven therapy with Keynote 811 if Zani is not yet available, but if we're able to use Zani in a parallel universe, then of course we'll go with the Horizon GEA treatment backbone.
Nice. And Jaffer, like, same question, but how long would you give neoadjuvant therapy before you would think about a surgery? Let's say they have a clinical CR, or maybe they have a residual disease on a primary on endoscopy.
That's right. So I think this is the type of case I usually take to my multidisciplinary, even before treatment starts. And then we usually get the recommendation of systemic therapy. So as Rutika mentioned, I would do Keynote 811, not do Durva-Flot because this is not the right situation for that. And then reassess and retake them to multidisciplinary conference, and then what we call consolidation at a later date, either with radiation or radiation plus surgery or surgery first, etc.
And John, so just my own editorial comment, when I get GE junction cancer and I'm HER2 positive, I would like to get HER2-directed therapy in the non-metastatic setting. But John, this case, we see these, like, how do you guys do it? Similar to?
Yeah, this is actually not an uncommon scenario. We see this quite a bit. And our general approach, number one, it is stage 4 disease. It's systemic disease, but it's fairly limited in its extent. But I would give this patient the best, who's relatively fit, robust, and wants an active therapy. I would give them the best available therapy. I think this is an excellent, if I had access to it, I think this would be an excellent patient for a Horizon GEA regimen. Chemo, Zani, and tislelizumab. Now, I think it is a fair critique to say that while there was a survival benefit with tislelizumab in this study, there was in the control arm there was no immunotherapy, right? And the question is, well, what's the value of tislelizumab? And I think Jaffer got to the real crux of the matter. If you look at a couple of different markers, it looks like tislelizumab is doing something in this trial that we're not yet capturing on this first interim survival analysis. The first is you see a pretty dramatic increase in the median duration of response when you add in the tislelizumab. So in somebody like this, I think that means something. That matters to be able to get not just a response, but a long-term durable response with good tolerability. Additionally, you do see those landmarks. Like, there does appear to be a tail forming on that tislelizumab arm that looks to be a little bit more impressive to me. So in the absence of a great control arm, I'm relying on my clinical judgment and my interpretation of that evidence. Now, what do? So we generate a response, and you come out to 6 months. What we do routinely at my center is we will have an endoscopic evaluation of the primary. We will biopsy that site. I would not be surprised if you had a complete response in the primary, in which case you're good. we'd look at this, assess whether that's viable or not. If there's still some viable disease, we may radiate that superclav node. But we're looking for what's left, and we may radiate some oligometastatic disease in that scenario.
Yeah, I think it is not that uncommon of a scenario as we get better biologic therapies. Rutika, this is basically two variations on the same theme, which is in someone with localized, operable, HER2-positive cancer, are you tempted to migrate the targeted agents and the metastatic regimens, which are very active, into the non-metastatic space? You can talk a little bit about some of the phase 2 data that we know exists, but do you think we're ready for this?
Not yet, I would say. Wish we were, but although how promising we've seen with the metastatic setting, I don't think it's prime time to move them into the locally advanced setting. We've seen the HER2 FLOT data, but again, a randomized phase 3 study in the locally advanced setting for HER2-positive disease is still pending. So until that time comes, I would still use FLOT plus durvalumab as a perioperative treatment strategy.
And Jaffer, same question to you.
Yeah.
And maybe just for the audience, tell a little bit about what's been done in the non-metastatic with the HER2, like the FER-FLOT and et cetera.
That's right. So there are a couple of studies, one from China and the other one European, where the PAT-CR rate is pretty high. So if you got HER2, perhaps 3 plus, PD-L1 positive, and you treat with you direct therapy to HER2 and PD-L1, you can get a very high PAT-CR rate, and some patients will do very well for a long time. But I think we cannot recommend that on a regular basis. This is something to keep in mind, because this patient, when they develop metastatic disease, which is highly likely, then I think you come back to HER2, but not initially.
Yeah. And John, I'm going to end this HER2 module by asking you the question that probably people have asked you, like, if Zani is available and you've got Pembro and you've got Nivo and you've got Tisli available, do you care about the PD-1 that goes with the Zani?
There is no evidence that one PD-1 is better than the other, right? So for me, I consider them to be interchangeable.
Yeah, agree. Totally agree. All right, perfect. We were pretty much right on time. John, you're going to continue and walk us through some Claudin data and talk a little bit about Claudin.
Thank you. Pleasure to be here tonight. I'm as surprised as you are that I'm here. All right, so let's... they at least changed the name out. Poor Dr. Ilsen is recovering from a viral illness, and I hope he is able to watch and approves of what I say. So let's go ahead and advance. So gastric cancer, obviously fifth leading cause of cancer worldwide, relatively rare in the West, more common in Asia in particular. And let's start first with the chemo regimens. This actually came up in the case from the community. Should we be giving 2-drug regimens or 3-drug regimens? If you look at the NCCN guidelines, they will say 3-drug regimens are not recommended. The reason is because they add substantial toxicity without a substantive survival benefit. So the NCCN and most of us up here on this panel would agree that in the palliative setting, 2-drug regimens, specifically FOLFOX, are preferred. And when we look at the regimens available to us in the clinic, biomarker-directed regimens, since 2010 with the TOGA trial, we've had trastuzumab available to us for HER2-positive disease, and we learned from KEYNOTE-811, at least from the third interim analysis, that if the CPS score is 1 or greater, to add pembrolizumab. For those that are HER2 negative, CPS scores greater than 1, we've got both Nivo and Pembro and tislelizumab as options. And as I'll go into here in a moment, zolbetuximab is also a very active biologic if Claudin 18.2 is positive at 75% or more. And for MSI-high disease, we know these patients absolutely must get a checkpoint inhibitor with or without chemotherapy based on that individual patient's circumstances. So patients newly diagnosed with metastatic gastroesophageal cancer, what am I telling my fellows to order? I think mainly it's IHCs right out of the gate. We need to know HER2 status. For me, the gold standard is IHC. If it's 3+, you're done. They're HER2 positive. If it's 2+, you need to reflex that to FISH to confirm amplification. We're also doing IHC for DNA mismatch repair deficiency, PDL1, and of course, in the last couple of years, Claudin 18.2 has been added to our panel. Now, there are also some genomic variants that can only be picked up out of an NGS panel. So after I've gotten all those IHCs done, I'm probably sending out for an NGS. And, what are we looking for there? Well, we've got NTRK fusions where we have a pan-tumor approval, BRAF V600E, RET gene fusions. And then we all have trials at our institutions for things like KRAS inhibitors and others where we would hope to match a patient to study. So let's dive into Claudin 18.2 here. This is a tight junction protein expressed in normal and malignant gastric mucosa cells, and it may become exposed on the cell surface during malignant transformation, and that makes it an attractive target. Zolbetuximab is the first molecule to make it in the clinic that targets Claudin 18.2, and it induces ADCC and CDC, just like we saw with Zani. So in terms of how often we see Claudin 18.2 expression, we have excellent data out of Japan from Dr. Shitara, Dr. Kubota's group. Single institution, 408 patients. The key thing to know is Claudin 18.2 overexpression is basically consistent across the molecular subtypes, whether it be a mismatch repair deficient group, an EBV positive group, or HER2 positive group. So it's kind of always in that 20 to 25% range, regardless of that molecular subtype. In terms of the prognostic impact, it does not appear to confer a negative impact either on first or second line chemotherapy or for later line checkpoint inhibitor therapy. So interesting to know that. Here's the data generated out of Japan showing that consistent level of Claudin 18.2 overexpression across all the molecular subtypes. And here's the data that they generating showing that Claudin positive tumors do not appear to have a substantially worse overall survival than Claudin negative. So we have a couple of trials now that have established zolbetuximab in the clinic. One is Spotlight, which I like because they use the backbone chemotherapy that I prefer, which is FOLFOX. Here, patients with previously untreated gastroesophageal cancer were randomized 1-to-1. They all had Claudin 18 staining. More than 75% of cells were positive for Claudin 18.2. And patients were randomized to Zolbe FOLFOX or FOLFOX alone. There's no immunotherapy in this study. And just advancing here to the results, we can see it was evenly balanced between arms. We can see progression-free survival better for zolbetuximab FOLFOX over FOLFOX alone. About a 2-month PFS advantage, has a ratio of 0.75, and it appears to be consistent across all the major subgroups, not impacted by region of the world, whether or not the patients had a gastrectomy or not, and then Lauren classification also did not impact results. OS also improved with zolbetuximab over placebo. So that's what established zolbetuximab in the clinic, and I'm going to move on here to response rate. I find this interesting. Although zolbetuximab improves both progression-free survival and overall survival, no significant increase in response rate, so response rate's not everything. Looking at treatment-emergent adverse events, I think this is really something we'll end up talking a lot about here. What do we expect to see when we give zolbetuximab? Well, it's these top three at the top: nausea, vomiting, and decreased appetite are the top three. The nausea and vomiting, maybe we'll talk in more depth with the questions, but it's fairly acute in onset and happens at its greatest extent in the first cycle of treatment. We can see here the onset of nausea and vomiting from this interval here almost always in the first cycle. But thankfully for all of us in the clinic managing these patients, it goes down substantially after cycle 1. This is the GLOW trial, which also demonstrated the activity of zolbetuximab, this time in combination with the CAPOX backbone. In the GLOW study, patients who were Claudin 18.2 positive, zolbetuximab CAPOX versus CAPOX. Primary endpoint was progression-free survival. And as we can see here, I'm just moving along, progression-free survival, 8 months for Zolbe CAPOX versus 6.8 months for placebo CAPOX. So statistically significant improvement in PFS. No subgroup appeared to benefit more or less from zolbetuximab. And then looking at this key secondary endpoint of survival, importantly, about a 2-month survival advantage for zolbetuximab with CAPOX over placebo CAPOX. Once again, no subgroup stood out as being particularly sensitive or insensitive to zolbetuximab. Response rate, I showed you the data earlier. No major impact on response rate by adding zolbetuximab, and that appears to be generally the same case here with the CAPOX backbone as well. When you look at treatment emergent adverse events, I do think that zolbetuximab adds a bit of toxicity. And, interestingly, globally, treatment-related adverse leading to discontinuation of any study drug only slightly higher for the zolbetuximab arm. But when you get into this treatment-emergent adverse events occurring more than 15% of patients, once again, it really sticks out. Nausea and vomiting. This is the toxicity we have to be prepared to manage, and we'll come back to our management strategies here in a moment with the patient cases. Once again, acute onset, that's that first cycle, maybe a little bit into the second cycle. So pooling together Spotlight and Glow all into one package, we can see here clearly zolbetuximab adds both progression-free survival benefit and overall survival benefit, and is a standard of care option for our Claudin 18.2 positive patients. So there is a major limitation to the studies I just presented to you, and that is the control. No patients were receiving immunotherapy, and I think that's always been a challenge for us in adopting zolbetuximab into our practice, which is the absence of the immune checkpoint inhibitor from those registrational studies. Thankfully, we do finally now have some data putting zolbetuximab together with FOLFOX and nivolumab in this first-line setting. This is the Illustro study presented here at ASCO GI just yesterday. We can see here median progression-free survival for this triplet in a non-randomized study, median PFS at 14.8 months. We also see a pretty interesting response rate all the way up to, it's 62% overall, but in the Claudin 18.2, high 68%. So I think actually for many of us who are treating a lot of these patients in the clinic, I think this is sufficient to bring the immune therapy in together with zolbetuximab and FOLFOX for a PD-L1 positive patient. Though we can see here as I advance, there is the Lucerna trial, which many of us are involved in, which is actually doing a proper prospective validation of zolbetuximab in a PD-L1 positive patient population. Here it's a chemo plus minus zolbetuximab with pembro. There's also a second-line study, Zelda, chemo plus or minus zolbetuximab. Clarity, I'll point out, is a new Claudin 18.2 ADC. And so that's one that we'll have to keep an eye on in a second-line or later phase 3 study. There's another first-line ADC study, this one an AZ molecule with 5-FU and a TIGIT PD-1 bispecific. And then there are other novel Claudin 18.2 targets. There's a Claudin 18.2 with 4-1BB bispecific that's already shown some interesting activity as well. So just some takeaway points here. Claudin 18.2 high expression seen in about 25% of patients. It's consistent across the molecular subtypes, does not appear to confer a negative prognosis. Nausea and vomiting are the key toxicity that we all need to be prepared to manage proactively. We'll talk about that. And we've got the registrational phase 3 study ongoing, looking at FOLFOX or CAPOX pembro with or without zolbetuximab. And then I think that we're not done developing drugs for this target, so we can expect to see CAR T cells, ADCs, bispecifics, and others getting into this space as well. Thanks.
That is awesome. Thank you for the whirlwind. I'm impressed that you were also able to work in KRAS inhibitors in the very beginning. So now let's talk about taking everything you said and bringing it back to the clinic. So here's 3 cases. You can read them, and everybody has these on slides, and I'll try to highlight some points throughout these cases. But Rutika, I'll start with you. So 82-year-old guy, Claudin positive, started on Folfox and Zolbi, actually has doing well with the nausea management, but of course started out with a highly emetogenic, multi-agent antiemetic prophylaxis regimen. So what do you do when people are doing well? Do you de-escalate? Do you not rock the boat?
If they've not had any nausea in the first 2 cycles, maybe with third cycle beyond, I will start to de-escalate and see how they're doing. That's kind of been my approach. I'm surprised 82-year-old tolerating well without any side effects. Sometimes age is just a number, as we say.
And do you feel comfortable doing that because of what John showed?
Yeah, I think the rates of nausea vomiting are significantly lower beyond the second cycle, so I feel comfortable kind of de-escalating beyond that point.
And Jaffer, touching on nausea strategies, you can comment on the same question, but also, you have discussed and mentioned before, there is in the label, there is essentially a loading dose with Zolbi. And can you talk about, 1, how do you feel about that? And 2, would you back off on antiemetics as well?
Yeah, so in this particular case, I agree with Rutika that slowly you can reduce the number of antiemetic drugs. And then, of course, you can continue to titrate as the clinical course expands. Now, in terms of loading dose, I stopped giving loading dose because of this. I think it is probably responsible for acute gastritis in patients who have the stomach in place. And so we just start with 600 milligram or 400 milligram, depending on the frequency of zolbituximab, and seem to be doing much better that way.
Yeah, I think it's a very good point. And Dr. Shitara is doing a randomized trial of this initial dosing versus just continuing at the more typical, maintenance dose. So we will actually have some data around this. But I think that's a very reasonable approach. I've done the same. John, I'm going to come to you with the sort of middle case here, which maybe talk about, so this asks the question of someone who had FLOT and had a recent recurrence, which is unfortunate and always a bad scenario, but they're Claudin positive. And so now they're in the first line setting with low-dose Folfox and zolbituximab, doing well but not responding. Doesn't sound like we know if he's progressing but not responding. Maybe theoretically, can you switch chemo backbones? Do you have concerns with synergistic toxicity with other chemo? And then have you ever continued Zolbi beyond progression and essentially swapped out the chemo as a strategy? Or do you think it's something we need to study?
My feeling is that if you did not have a response to first-line zolbituximab, you're not going to have a response to second-line zolbituximab. So while I do agree FOLFIRI is a very reasonable chemotherapy regimen, I would not be thinking to continue it without more evidence out there to support that practice. It's interesting. There was a study looking at trastuzumab past progression in HER2-positive gastroesophageal cancer, and that was a negative trial. So it's important to know that the biology of gastroesophageal cancer is one of heterogeneity. So if you're not seeing benefit, it may be because that target is just not, kind of homogeneously expressed. There's something biologically going on that I think tells us here that we need to move on to a different strategy, to me. But it's certainly worthy of further study.
And in theory, let's say different scenario, patient has horrible neuropathy and is not a candidate for oxaliplatinum, but it is a true frontline, newly diagnosed metastatic patient who's Claudin positive. What do you do in that scenario? Let's say you've got or actually I'll ask Rutika, you get this question. So someone who's PD-L1, let's say PD-L1 negative, Claudin 90%, and has bad baseline neuropathy, how would you approach this patient?
You should be doing that next trial, just like breakwater, right? No, I think that's a data-free zone right now. So until more safety data becomes available, I'll be a little skeptical. Although 62-year-old, I could try a little bit lower dose irinotecan to start with and see how they tolerate. Since they've already had an esophagectomy, maybe the nausea vomiting won't be so bad.
And Jaffer, you've had a lot of experience with Zolby. Same scenario.
Yeah. So if FLOT failed within few months, like it says, 3-4 months, I would not go to FOLFOX because that's basically using the same chemotherapy. And so we have switched to FOLFIRI-zolbetuximab in such cases, and we're going to publish a paper. And it's very well tolerated. Of course, again, you don't use the loading dose and manage patient very carefully.
Yeah, I agree. It's reasonable. I know you've also published on FOLFIRI-nivo in the similar scenario.
That's right.
With before Claudin was available. John, I'll come to you because you presented the Illustro data. It's encouraging, I think, that it's like directionally similar to the TST-001 combination that we have also seen a little bit of prelim data. But now you've got that patient in front of you in clinic. Zolby's approved, Pembro-nivo are approved. Patient is a candidate for FOLFOX. Are you going to try to get this Illustro regimen?
Yeah, I think we are blessed in the United States that we have sometimes access to things even before we've seen the prospective randomized phase 3 study. And that data is very compelling to me from the Illustro, and I would consider trying to access that combination for the right patient who has all the biomarkers in place. And I would, when I have the peer-to-peer, I would cite that evidence.
Rutika, same question. Jaffer, I'll ask you the same question too, because this is something that we're all going to start seeing more of.
Yeah, I think young patients, stage 4, Claudin and PD-L1 positive, I'll definitely try chemo-Zolby immunotherapy for those patients. Again, as John mentioned, a peer-to-peer would be necessitated, but we'll do that with the Illustro trial. And
Jaffer, same scenario.
Yeah. So if we don't have phase 3 data, so in this particular case, with CPS of 5, I would use Nivo or Pembro, Tisley with chemo, because especially with Nivo, we all know we have 5-year survival data, and there is a robust, tail of like 15 to 18%. We don't know whether that will happen with Claudin, so I would favor immunotherapy, chemotherapy, and when there are more data available, I would definitely like to combine the two.
Yeah, me too. I mean, I also recognize that a lot of our patients don't even make it to second-line therapy, so we really need to take our best shot here, and I think that does represent our best and most active combination that we've seen for this scenario. It's always humbling in these phase 3 trials. 40-60% of people get any subsequent therapy.
Yeah.
It's just a reminder it's a bad cancer, and some rationale to put our best shot early on. Let's move on to another case. So this is a young woman, HER2 negative, PD-L1 negative, Claudin positive, is having some real nausea, grade 3 nausea on zolbetuximab. What are your sort of management strategies to deal with this? It happens. I mean, we know that it happens. But at the same time, we also know the drug is active. So what is your sort of go-to moves to keep people on? Rutika, you can get first dibs.
Yeah, so I think as Jaffer mentioned, eliminating the bolus is one strategy, but when I typically give zolbetuximab in the clinic, I'm kind of loading them with all antiemetics, 5-HT3 blockers. I'm giving them olanzapine, I'm giving them dexamethasone, famotidine. And despite that, if they're having any form of nausea, when the rate change happens, that's typically when I see more nausea happening. I pause the infusion, give them IV fluids, give them metoclopramide, resolves, and then I'm able to resume the infusion, and they're able to complete in most of the cases. Again, a lot of reassurance is required to patients, in my opinion, trying to educate them, and then obviously give them some breakthrough antiemetics when they go home.
And Jaffer, what about you? And maybe address the second comment, which is about either splitting up the dosing of Zolby or splitting up the components of FOLFOX and Zolby. Do you do that? Do you do it in particular scenarios? And what else do you do to manage nausea?
Yeah. So I think, in this case, I will maximize the antiemetics, or let's assume that it is maximized already. and Zolby is causing significant nausea, vomiting. So you could split Zolby, you give it for half the dose, stop for half an hour, then do the half the dose. Second would be to prolong Zolby infusion considerably, which is really a problem for everybody, patient and the clinic staff and all that. But the third thing you could do is reduce the dose.
Right.
Yeah, I find what I do in practice the most common is interrupt the dose. Like you said, go for half the bag or until nausea, stop, give it 40, 60 minutes, and then resume and get it in. It is a long day for patients, particularly in the first infusion, but those strategies are important for management. John, I'm going to come to you with this bottom one, which is sort of a common clinical scenario. We know our patients get PEs periodically. So someone who is claudin positive, doing well on frontline Folfox and Zolby, now fully anticoagulated, let's assume that clinically they're well. Do you have any concerns about drug-drug interactions here?
No, I would feel comfortable resuming the dose of zolbetuximab after the patient's fully anticoagulated here.
Yeah, me too. I think
Yeah.
this one is relatively clear. I think we all agree. All right, coming up on last couple cases. So 67-year-old guy, stage 4, GE junction adeno, claudin positive, PD-L1 negative, HER2 negative, planning to give Folfox and Zolby. Talk about the nausea, but maybe, John, since you presented the data, I'll also come to you. Do you have any reservations about giving this Folfox, Zolby, Nivo triplet in a PD-L1 negative patient?
Yeah, I would. I think for a CPS 0, I'm less inclined to give immunotherapy or immune checkpoint inhibitor therapy. So this is a classic patient where it would be Folfox plus zolbetuximab in my clinic. In our case, at our institution, once again, it's a learning curve whenever you bring these new molecules into the clinic and into the treatment room, not just for us as doctors, but for our clinic staff. Just to reiterate that point, slow infusion for that first cycle, right?
Yep.
The bad news is also the good news. The bad news is that the nausea and vomiting can be extreme in some cases, not always. But it's usually just in that first cycle, and it really tails off after that first cycle. So if you can get them through that first cycle, it's probably going to be okay. So we throw everything we've got to slow that infusion. We can even drop the loading dose, go to a lower dose, holding everything. You throw everything you've got with your high anti-emetogenic regimens. The other pearl that we discussed right before getting up here is the fact that if the patient has had a gastrectomy in the past, they also are much less likely to have that extreme nausea and vomiting. So those are also some pearls to keep in mind.
Yeah, I agree. I think this next question asks about, mentions something that I think we all have seen in practical point, which is someone's writing in and says they've had 3 patients treating with zolbetuximab, has found lorazepam to be helpful with nausea. And have we seen this? Yes, I think all of us have seen this. And the nausea and vomiting with Zolby is not the typical centrally mediated nausea. This is presumably an effect locally in the stomach lining. And I agree, lorazepam often does help, and people get anxious a little bit too, so there may be some component of rationale just to manage the longer day and the anxiety that comes with chemo. Because remember, these are patients who have new diagnoses. They've never had chemo before either. It's logical to be a little bit nervous coming into this. I want to move on to this next couple cases here. So diffuse type, Jaffer, I'm going to come to you with this one, but young patient, poorly differentiated diffuse type gastric, PD-L1 positive, CPS of 4, claudin positive. Patient is quite symptomatic from their disease, and you need some cytoreduction in order to get their symptoms under control. Seeing the Elestro data now, if everything's available to you, what are you going for in your most active systemic therapy here?
Yeah, so I think Elestro is good information, but it's not changing standard of practice. So in this particular, I don't use immunotherapy unless CPS is 5 or greater, because we already have that data with particularly Nivo, and I think Pembro may be similar. So I would just use Zolbi plus chemo in this particular case.
And maybe, Rutika, I'll come to you, and maybe just more broadly, like, when do you look at response rate to make clinical decisions? I mean, PFS and OS are, of course, the benchmarks that we look at when we're, like, deciding on approvals and things, but if you're comparing chemo IO and chemo Zolbi, like, do you think of these with different response rates?
I think so. I mean, if a patient is very sick, if you're concerned about gastric outlet obstruction, for example, then in those cases, I start with chemotherapy alone and then add on the biomarker-driven therapy. I agree to Jaffer's point that I was historically doing immunotherapy just with CPS 5 or more. But honestly speaking, the place that I practice, the majority of my colleagues are now having a lower threshold for immunotherapy treatment. So I've kind of reduced my cutoff at this time to 1. But again, in this acutely sick patient, I would first like to just start with chemotherapy before I add on more therapies onto it. Zolbetuximab, I would be a little concerned given the acuity of the illness, and how would I be able to differentiate between disease progression, rapid disease progression versus toxicity from the drug itself. So probably hold off on Zolbi.
Yeah, I would make the point at least that the objective response rate in CPS less than 5 FOLFOX Nivo is not significantly different than the response rate for FOLFOX Zolbi either. You only get into that 55, 60 when you get CPS 5s, 10s, at least from the 649 data. Jaffer, I'm going to come to you with this bottom case, which is about another young patient, metastatic gastric cancer with peritoneal disease. This case, you've got the full IHC HER2 3+, PD-L1 CPS 10, so high, and Claudin positive, and they're a candidate for everything. How do you, I guess this is a question about prioritization of biomarkers, and how do you think through that? Do you look at the hazard ratios, the absolute numbers across trials?
That's right. So I think this is a increasing challenge in the clinic. When we test more biomarkers, you're going to have double positive, triple positive, and maybe more. So in this particular, you have to rank, and I would rank HER2 positivity as number 1, PD-L1 will be number 2, Claudin will be number 3. And this is just based on the maturity of different data. So this patient I will treat with Keynote 811 and hold off on targeting Claudin.
And John, same to you, but let's say Zani is now available. And also, because the Horizon trial used CAPOX or 5-FU platinum, would you give FOLFOX with Zani typically? We saw that in the phase 2, but not in the phase 3.
Yeah, I think that was done in the phase 3 study just for a practical matter of study execution. I do feel comfortable with the data generated out of the phase 2 with the FOLFOX backbone. Interestingly, and this is another very important point, that in that phase 2 experience, which was non-randomized with FOLFOX, one of the changes that was made was not just to institute the loperamide prophylaxis for the first 7 days. They also dropped the 5-FU bolus in part 2 of that study. And after dropping the 5-FU bolus from FOLFOX and putting in the loperamide prophylaxis, the response rate to FOLFOX and zanidatamab was 95%. So I feel comfortable using the FOLFOX backbone, but I would also strongly encourage anyone considering that to drop the 5-FU bolus, because I think the 5-FU bolus does not add much in the way of benefit and add substantial toxicity.
And Rutika, same question, but let's say, should we explore trials that do everything? Like, what if you just added the Zolbi on top of, say, Keynote 811?
On top of Keynote 811.
Yes, so you're giving everything. You're acting on every biomarker.
You could try to do that, but as Jaffer pointed out, I think based on what we know about these biomarkers, I think HER2 becomes much more actionable than any other biomarkers here. Your one option could be, because again, we see HER2 loss as well in our patients. If they do have HER2 loss, then subsequent lines of therapy, and if they remain to be Claudin 18.2 positive, there are multiple Claudin agents in development which are also looking in the second line space, so that could be an opportunity for targeting Claudin.
Yes, well, you are bringing us home, and you're now taking us to Module 3, where you're going to tell us about immunotherapy strategies in this disease.
All right, thank you. So I'll run through these 4 different highlights here. So we're going to be talking about what are some of the clinical and biological factors that affect my choice of upfront treatment for patients with metastatic GEA cancers. What is some published data surrounding treatment landscape for HER2-negative patients, and what is the impact of PD-L1 expression on these outcomes? We'll talk a little bit about HER2 positives and especially the Keynote 811 data here. And then what is the clinical utility of immunotherapy in relapsed refractory settings? And I'll probably cover a broad umbrella of immunotherapy, not just the checkpoint inhibitors like we know of. Sorry, the font size is small here, but essentially this is an algorithm that I walk through with any patient that walks into the door with metastatic or unresectable GE junction cancer or gastroesophageal cancer. So the biomarkers of relevance are MMR, HER2, PD-L1, Claudin 18.2 in that order. If the patient is mismatch repair deficient or MSI high, then as we have pointed out before, it's immunotherapy plus minus chemotherapy. If they are mismatch repair proficient or MSS, we check for HER2 as a next step. If they're positive for HER2, we're checking for PD-L1. PD-L1 positive, then it's your Keynote 811, which is chemo, trastuzumab, pembrolizumab, and I put in a question mark Horizon GEA-01 because I didn't have privilege to the slides when I created these, but hopefully that would kind of be practice changing here and would replace Keynote 811 in the future. PD-L1 negative, right now we're treating patients with chemotherapy plus trastuzumab, but again, we'll have to see if there is a regulatory approval for the Horizon GEA, is it going to be PD-L1 restricted or all comers? If you're HER2 negative, then we move to PD-L1 testing, PD-L1 CPS of 5 or more. That is kind of my ideal cutoff, would be chemo with any of the checkpoint inhibitors available. That's nivolumab, pembrolizumab, or tislelizumab. If their CPS low, I'm checking for Claudin 18.2 positive, then I'm giving them chemo plus zolbetuximab. And then again, here is where the Illustro data comes out, where we're hoping for some randomized phase 3 data readout in the near future. And if you're Claudin negative as well, my current standard practice is to do chemo alone, but then in some patients, I've had patients being referred from the community who have already started on chemo plus immunotherapy, so that at least my cutoff, I keep them as CPS of 1 or more in that case scenario. So choice of chemotherapy, I think this has been touched on by John previously, but typically a doublet chemotherapy with fluoropyrimidine and platinum. Capecitabine or 5-fluorouracil, a platinum agent could be oxaliplatin or cisplatin. This is per standard guidelines. However, my standard chemotherapy regimen is 5-fluorouracil with oxaliplatin. And then we also talked about that there is really no role for a triplet regimen, but with one caveat being if there are no actionable mutations and this patient is potentially eligible for resection of both the primary and metastatic site, then we would consider FLOT unless and until we know that this is going to be just for a limited number of cycles. And as Jaffer pointed out, there is an ongoing clinical trial looking at FOLFOX plus minus Nivo versus FOLFIRINOX plus minus Nivo in the Alliance trial. So moving gears into what is kind of the currently available data in the HER2 negative space. So the first trial I'll be discussing would be the Checkmate 649. Again, it's a randomized open label phase 3 study with no known HER2 positive status, ECOG performance 0-1, randomized to chemotherapy versus chemotherapy plus nivolumab. And you had dual primary endpoints of OS and PFS. This is, again, very tiny to read, but the boxes that are being highlighted is you can see what proportion of patients were enrolled in Asia, which is about 25% of the patients that were enrolled in Asia. Then you have about 22% of patients that had peritoneal metastases, and then diffuse type is kind of highlighted in the red box as well. Again, when we look at overall response rate, and this is something that Sam pointed out, when looking at just at the right side of the table right now, where we compare chemotherapy versus chemo plus nivolumab, you see the response rates kind of going from about 45% to about 58%. And then when we use it, do it in the PD-L1 CPS 5 or more, then you see kind of an incremental increase in the objective response rate from 45% to about 60%. And this is kind of the 3-year follow-up data from Checkmate 649, kind of showing you the OS benefit with the addition of nivolumab. The left-sided KM curve showing it for the overall survival in PD-L1 CPS of 5 or more, and the right side showing it for the all randomized patients. Again, just kind of giving you a brief summary, it would be improvement of 11.1 months with chemotherapy alone arm to about 14.4 months in PD-L1 high population versus about 13.7 months in all randomized patients. And this is kind of your PFS data, also kind of very similar to what we see for the OS data. Again, the wider separation of curves as you see for the PD-L1 high patients as opposed to the all randomized patients. Next, we'll move on to the Keynote 859, which is another randomized double-blind phase 3 study in the metastatic setting. Again, HER2-negative patients, randomizing to chemotherapy versus chemotherapy plus pembrolizumab, with the primary endpoint being OS. So there is just one primary endpoint as opposed to dual primary endpoints in the Checkmate 649. Again, here it kind of shows you that the Asian population is slightly higher in this study, and then we're talking about gastric cancer. About 80% of these patients had gastric cancer. In the Checkmate 649, it was about 70%. Again, looking at overall response rate, very similar to what we saw in the Checkmate 649. However, you'll notice here that the cutoffs are different for the CPS. So in Checkmate 649, you had your all randomized patients and then a cutoff of 5 or more. Here you have your ITT population, your CPS of 1 or more, and CPS of 10 or more. This kind of shows you that pembrolizumab improves overall survival across your all populations intention to treat PD-L1 positive CPS of 1 or CPS of 10 or more. And this shows, again, improvement in progression-free survival. And you can start to see that as we go from CPS cutoff of 1 to CPS cutoff of 10, the wider separation of curves and incremental benefit as we select for higher PD-L1 score patients. Next, moving on to Rationale 305. This is the third study that we have with the checkpoint inhibitor tislelizumab. Again, very similar patient population, comparing chemotherapy versus chemotherapy with tislelizumab. One unique feature about this trial was the stratification factor for patients with peritoneal metastases. Again, this is one more thing that I would like to highlight here is the study used the TAP scoring method. And if you look at the TAP scoring versus the CPS, an overall agreement of 82% was seen. And the table and the written language kind of tells you what the TAP kind of means. 44% patients with peritoneal metastases were enrolled onto the study. And again, a primarily Asian study with about 75% patients enrolled in Asia. This kind of shows you the overall response rate with tislelizumab over chemotherapy. It may be slightly lower. Could it be due to heavy burden of peritoneal metastasis patients? But again, you do see an incremental benefit over chemotherapy when it comes to their overall response rate. Again, this showed both OS benefit in all randomized patients as well as patients in TAP of 5% or more, and also showed PFS benefit in all randomized patients and in patients with TAP score of 5% or more. And again, as I mentioned earlier, there's also the stratification factor with peritoneal metastases. So there was an improvement in overall survival in patients with or without peritoneal metastases when tislelizumab was added to chemotherapy. And then moving gears onto HER2-positive setting, this is the Keynote 811 study, randomizing patients to chemotherapy versus chemotherapy plus trastuzumab versus chemotrastuzumab, pembrolizumab for HER2-positive disease. And this is where the combination was first approved based on their overall response rates, and you see these great waterfall plots. And then, however, when the final analysis was done for overall survival, the overall survival benefit was limited to your PD-L1 positive patients, after which the FDA kind of retracted the initial agnostic approval, but limited the approval to HER2 positive, PD-L1 positive patients. So again, this kind of shows you that it improves PFS as well. And then I mentioned about other immunotherapies in refractory settings. So again, there is currently no randomized data to show the use of checkpoint inhibitors once checkpoint inhibitors have already been used in the frontline setting. But when we talk about the general idea about immunotherapy, it will be hard to miss that there are other immunotherapy options, such as CAR T therapy for refractory gastric cancer. And we've seen a Claudin CAR T trial that has been conducted in China, which showed some improvement in OS and PFS. Again, the duration of response was short-lived, so that's something to work upon. But there is also this oncolytic virus called OBP301 that is currently an ongoing trial at our institution, looking at in combination with pembrolizumab in patients that have previously received checkpoint inhibitors and have progressed. But some preliminary data shows that there is no added toxicity and well tolerated. So my conclusions are that key biomarkers in the advanced space, MMR, HER2, PD-L1, Claudin 18.2, that dictate your first-line treatment. Doublet chemotherapy is always preferred over your triplet combination. And then in terms of checkpoint inhibitors, you have the option of nivolumab, pembrolizumab, tislelizumab. And again, incremental benefit is seen with higher PD-L1 cutoffs. In your HER2-positive patients, as we stand here in January 2026, your standard still remains to be chemotherapy plus trastuzumab in HER2-positive PD-L1 negative patients, but chemotherapy plus trastuzumab plus pembrolizumab in your PD-L1 CPS 1 or more patients. And then again, at this point in time, there is limited benefit of any checkpoint inhibitors in the refractory settings, but there are other therapies that are being explored.
Awesome. Thank you very much. Shown us immunotherapy in almost every biomarker subset now, which, who knows, maybe we'll stop testing for PD-L1 at some point if we have a whole bunch of really active biologics. All right, a bunch of good cases to get through. Top here is a squamous patient. So we haven't really talked about squamous patients very much, certainly probably the minority of what all of us see, but we do have some data with immunotherapy there as well. So Rutika, I'll let you continue on the immunotherapy with this specific question, which is about PD-L1 cutoffs that you use in the clinic for squames and adenos.
Yeah, I mean, based on the ODAC review and the FDA guidance, I think the PD-L1 cutoff of CPS 1, actually not even CPS, cutoff of 1 or more is being universally used across both squamous cell carcinomas and adenocarcinomas. So that's kind of the cutoff that we go with.
And I'll just go right down the line. John, same question. What cutoffs do you use in the clinic for typical patients, squam and adeno?
Yeah, I mean, for me, it's 1. I recognize that the higher the number, the better results you get. The challenge I've had in the clinic is that I find the PD-L1 scores to be exceptionally variable, particularly if a patient comes from outside. I can't tell you how many times my pathologist has a wildly different PD-L1 score than whatever, central lab or outside hospital scored it. And I think this really drives home the point that simplicity on a biomarker is, at the end of the day, probably the best policy where you've got very mixed data. So I like 1 as a cutoff just because I think no expression versus some expression is about as reproducible as you can get with this biomarker.
Yeah, and Jaffer, what are you using in the clinic for squames and adenos?
So squam, I use 1, but for adeno, I use 5.
Yeah, I think everybody could make a very defensible argument for everything that you guys have said. Let's go to this next case, and Jaffer, I'll continue with you. Kind of interesting case, squamous gastric cancer, not specifically not GE junction. 85% very high PD-L1 score. FOLFOX and Nivo had a great response. Do you think that intrinsically squamous cancers are more sensitive to checkpoint inhibition?
Yeah, I think so. I think squamous is more amenable to immune modulation. So I certainly think that is the case.
Yeah, I think so too. And the vast majority of squames are PD-L1 positive as well.
Yeah.
Let's go on to the next case. John, I'm going to come to you to start off this one. So 70-year-old guy, hypertension, diabetes, peripheral neuropathy, COPD, real-world patient that we all see, gets GE junction cancer with multiple liver mets. ECOG is 2. HER2 negative, PD-L1 CPS is 25. MSS, what's your go-to in this scenario? Run-of-the-mill, multiple comorbidities, PD-L1 positive patient.
This is my guy.
Yeah.
This is my clinic right here.
This is North Carolina for you?
Yeah, this is what we have. And you know, assuming Claudin 18.2 negative, then FOLFOX Nivo would probably be my preferred combo. CPS of 25 is pretty impressively high. If I was worried about FOLFOX in this, well, I mean, they've specifically called out the neuropathy, probably to get me off of the oxaliplatin. I have also been known to give single-agent pembrolizumab in people that I didn't think were appropriate for cytotoxic chemotherapy. You know, when you get to the peripheral neuropathy, then there's questions of how bad is that neuropathy. And Jaffer, you mentioned that in your clinic you would even consider FOLFIRI in such a patient, which I think is reasonable as well. But if it is, you know, I might start with a dose modification of the oxality as well and really lean in on the ICI, the immune checkpoint inhibitor.
And Rutika, you talked about ICIs and talked a little bit about the toxicity, but obviously pneumonitis is a known thing. Let's make this person's COPD a little worse. They're on 2 liters of oxygen coming into your clinic.
Yeah.
Do you worry and say, like...
No, with single agent immunotherapy, like with immunotherapy, just one immunotherapy agent, I'm not so worried. Of course, I'll educate the patient, have them call the clinic if there is even a slight worsening of symptoms or more oxygen requirement. But as long as it's not Ipi-Nivo, I would be comfortable giving chemotherapy with a checkpoint inhibitor in this patient. Yep, agree. All right, let's get to the next one. So, 66-year-old guy, metastatic GE junction to the liver, HER2 negative, PD-L1 CPS 10, also has several comorbidities, in this case, borderline renal function. Just newly diagnosed, thinking FOLFOX Nivo. Jaffer, what do you think about sort of the relative gain across the PD-L1 strata with checkpoint inhibitors?
So, I mean, we know that PD-L1 negative is a definite benchmark for no benefit. 1 to 4, probably no benefit in adenocarcinoma, definite benefit in squamous. And 5 to 10, there is definite benefit. And 10 and higher, and probably there are no gradations above 10, but 10 and higher is even higher benefit overall.
And John, I'm going to come to you because you mentioned single-agent Pembro. Do you factor in the liver mets? If someone has a bunch of liver mets, are you going to be less likely to give them single-agent Pembro? And maybe explain like why that you might think about it.
Yeah, I mean, it's a really great question, and the data with Pembro suggests single-agent activity where CPS is 10 or more. So that's why that's attractive in this case. There is substantial evidence that liver metastases in certain solid tumors do essentially create an immune tumor microenvironment that is more tolerogenic towards tumors. So it's an interesting theoretical question. It may be that I have not seen the paper, but I've not seen evidence that, at least in gastroesophageal cancer, liver mets would predict for resistance to such a strategy. Certainly when you get into colon cancer, there's very strong evidence that liver mets would confer resistance. in microsatellite stable colorectal cancer, there's very strong evidence that liver mets will confer resistance to immune checkpoint inhibitors. But yeah, I don't think that's the case for gastroesophageal cancer.
Yeah, I believe Kohei may have published a retrospective of later line, like Rego-Nivo, looking at liver mets and some slightly differential outcomes, but not this scenario, as you pointed out. All right, let's get to another case, a couple cases here. So 79-year-old woman, HER2 positive, very PD-L1 positive, CPS of 30, also has a coexisting autoimmune condition. And Jaffer, I'm going to come to you on this one. How do you think about the severity of the autoimmune disease? In this case, RA, like, does the patient need to be on a disease-modifying biologic for you to say, I'm very hesitant? How do you think through these kind of comorbidities?
Yeah, so in this patient, I have a group of rheumatologists that are very experienced. So I would not start on anti-PD-1 therapy here. You can start on chemotherapy, maybe trastuzumab, and then refer the patient to the rheumatologist. And our rheumatologists now feel bold enough to tell you, use it or don't use it. So I would and then they follow.
Yeah.
So which is even better.
Yeah, we have the same luxury of having an immunotherapy complication service where we have access to people who basically help us with this exact same thing. Rutika, same case, second case, same theoretical concern. So someone, very, very healthy patient, long-standing Crohn's, not on steroids, no flares in many years, and metastatic disease. Very PD-L1 positive, HER2 is negative, hasn't started any therapy. What would you offer this patient?
Yeah, I mean, I've had a recent case of a MSI high patient with history of Crohn's disease. And I was okay giving them single-agent immunotherapy. Again, as long as they are meeting with their IBD specialist and they're in close proximity, I would try to challenge them with FOLFOX plus immunotherapy. Here, the PD-L1 score is really 55%, which is high. If it was, and again, I would check the MMR status here as well. But if the PD-L1 was, as Jaffer said, 1 to 4, or even like 5 to 10, I would be a little hesitant. 10 or more, of course, I would be compelled to try an immunotherapy.
Yeah. No, I agree. I think this is someone who I would think of doing it as well. Let's move on to another case, and then I'm going to get to some of the online questions that have come in. So, John, I'll come to you on the top one. Young patient, Claudin positive, CPS of 12. We sort of touched on this a bit, prioritizing biomarkers. Are you going to do FOLFOX-Zolbi or FOLFOX-Nivo? Let's say you cannot get the triplet combination.
Because as we've already discussed, my preferred in this case would be FOLFOX-Nivo-Zolbi. But when you start to get in that CPS greater than 10 range, that's where you really see the bulk of the benefit captured with the immune checkpoint inhibitors. So probably in this case, I would be leaning in more towards FOLFOX-Nivo for a couple reasons. Number one, I think the toxicity profile is pretty favorable for nivolumab. Number two, you made the point about response rates, right? We don't see necessarily a better response rate with Zolbi, but when you get a CPS greater than 10, that's where you really start to stack up that response rate advantage for immune checkpoint inhibitors. So I do think I would prioritize the immunotherapy in that particular very rare scenario.
Yeah. Jaffer, I want to spin this a little bit when I come to you. So this has to do with retesting of biomarkers, but let's say this same case, the 48-year-old woman 4 years ago had a gastrectomy, and you had the biomarkers from the gastrectomy, because a lot of us are reflexively testing the surgical samples anyway, and now they have a recurrence, and you biopsy and you know it's a gastric cancer recurrence. Are you repeating Claudin and PD-L1 on this?
Yeah, I do every time I get an opportunity, repeat everything. So in the clinic, one thing we do wrong, but we don't have a choice, is we biopsy the primary and treat the metastases in most cases. And I think, biologically that is completely wrong, because we have published at least 3 papers where in the same patient you take the primary, take another metastasis, and their molecular profile, either transcripts or immune proteins or immune cell infiltration, is all different. And we get lucky that we give one regimen to the heterogeneous tumor, and sometimes we get a lot of advantage. But I'm starting to biopsy and I'm not hurting the patient, to biopsy the metastases and treat the metastases.
And I'm going to ask you, Rutika, a very practical spin on this question that gets to an online question, which was about someone's progressing on trastuzumab. When you decide, do you yourself look at the scan and say, tell your radiologist that, hey, the liver lesion is getting bigger, I want to biopsy an enlarging lesion? How do you sort of manage it?
Yeah, I typically would prioritize an area that is progressing over something that's stable, as long as it's within clinically feasible. But to your point, in addition to that, and Jaffer had kind of mentioned that previously, I also do liquid biopsies for my patients. So at baseline and every couple of months, just to see what if they are ERBB2 amplified on ctDNA at baseline. If it's a HER2 positive, then it's more reliable to check their HER2 status on ctDNA if a tissue biopsy is not feasible at the time of progression.
And John, I know you've done a lot of ctDNA work in your career. So let's say this patient is progressing on trastuzumab and the ctDNA is negative. Are you ready to call that person HER2 negative, or are you going for a biopsy? And what about the converse? If the ctDNA is positive, do you need a biopsy?
Yeah, so great question. So I think there's sometimes a tendency to think that when you do not detect HER2 amplification in blood, that person is HER2 negative. That's not true. In general, the limitation of the circulating tumor DNA assays is that you need a high tumor fraction or high degree of ctDNA shedding in order to detect any amplification event, whether that's ERBB2, HER2, or any other amplification. Tumor fraction, sometimes 5 to 10% at least, to pick up an amplification. So I would trust a positive result. The test is specific. You don't usually get false positives out of these. If it's negative, you have not proved a negative, right? If it's really a not detected. So if you really need to know HER2 status, you're going to have to go find a piece of tissue at that point. It's unfortunate. Now, interestingly, Dr. Shitara's group in Japan looked at this question of, this was an exploratory analysis out of Destiny Gastric 01, where they looked at the impact of ctDNA positive for HER2 amplification versus negative, and found that actually your response rate goes up pretty significantly to second-line TDXD to refractory TDXD if your ctDNA is positive as compared to negative. But you can still benefit if you're ctDNA negative. So, it's something to keep in mind.
Yeah, agree. Jaffer, I'm going to ask you something that's not on there, but it's something that someone wrote in, which is, we didn't really touch on preferred approach for MSI high, newly diagnosed patients, stage 4. Mm-hmm. Let's assume they're HER2 negative and Claudin positive. You can answer if they're Claudin positive or negative, if it would change anything. But what is your go-to for frontline MSI high patients? Yeah.
So again, just to remind everybody, you have to make sure that they can tolerate immunotherapy. And we use Nivo plus Ipi in almost every patient who can handle that, because the best results are with that. You don't use chemotherapy, and we have data, and I think you wrote a beautiful review not too long ago that the response rate is high, sustained response rates, including in metastatic setting there can be complete pathologic response. So the other option will be to use Pembro or Tisley or Nivo alone.
Yeah, Rutika, I'm going to ask you the same question, but also ask you, how long do you treat those patients if they are doing great?
So if they've had a complete response to treatment, then you can always argue to stop treatment after 2 years. But if they still have residual disease, and again, prove it on biopsy, then I would try to extend it beyond the 2 years time point, provided that I don't get a pushback from payer.
John, I'm going to ask you sort of variation on the same question because I think it's an important practical point. But when you start someone on FOLFOX and let's say Nivo, do you do a pre-specified number or duration of doses of FOLFOX, or do you treat to drops in platelets or neuropathy before you drop the oxaliplatin? And then what is your maintenance? Is it 5-FU Nivo? Is it Nivo? Is it individualized?
Yeah, so if you look at the data from our control arms of these randomized phase 3 studies and look at how the experimental arms are doing, what we're seeing are people are living longer and longer, right? So when the median OS is less than a year, things like neuropathy become less of a concern. But if people are going to live 2, even up to 3 years with metastatic disease, symptomatic peripheral neuropathy is a significant quality of life concern. So for me, I'm looking at that patient's care continuum, not just what they're on in first line, but what their life is going to look like a year later. When you consider that, I think that most of the benefit you get from oxaliplatin is in those first 6 to 8 cycles. So for me, I am rapidly tapering off the oxaliplatin after typically 6 to 8 cycles to prevent that patient from having major quality of life implications from the oxali. I usually will keep the 5-FU going because it rarely causes significant toxicity together with that biologic. And then when I get out to month 6, if that patient still has excellent disease control, I'm thinking about even dropping that 5-FU because carrying around that pump for 2 days is nobody's idea of a good time. And so if I think I can get away with it, I'll try to go down to just the biologic at month 6 and see how long I can stretch that. 2 advantages. Number one, that patient gets a better quality of life as they're off all cytotoxics. The other advantage is I can always bring the cytotoxic back in the future because I haven't burnt a bridge. So that's my own approach. I don't know what you all do, but that's how I approach it.
Jaffer, we got a minute, so is your approach similar? Same question.
Yeah, I would do the similar thing, yes.
Yeah, me too. Mm-hmm. And I often will switch the patients to monthly Nivo or something if they're really
absolutely.
doing well, getting in there. Yeah, I think so. All right, Rutika, you're going to get this one, which is a 59-year-old guy with diabetes and gastric cancer, PD-L1 positive. Also, in this case, we introduced the TMB. So TMB is, let's say 10, let's say it was 20, or let's say it's 50. How much do you care? And they refuse chemo. So highly PD-L1 positive, TMB high, do you feel comfortable with single-agent checkpoint?
With a 59-year-old, probably not. I would kind of quote the data, understand what are some of the barriers to, taking chemotherapy. But again, quote the data the best data we have is still in with combination with chemotherapy. Unless and until the MMR comes back to be deficient, then probably a doublet immunotherapy like Jaffer mentioned. But TMB is kind of losing its importance, I would say, especially in the GI space, and more and more. There's more and more data to now suggest that TMB cutoff of 10 really does not hold for across GI cancers.
And Jaffer, there's a question, the write-in question that I'm going to come to you, which is about, within the Zolbi data and the Spotlight and Glow, we did see some albumin drops over time and some potential gastritis. Mm-hmm. Do you have any specific suggestions for managing this and when you see it?
No, I think gastritis, there is really no good evidence. We have done biopsies in several patients. It's eosinophilic infiltration, and it's a patchy erythematous area. Hardly any ulceration, no perforation so far, and there is no treatment. My pharmacist wants to give Benadryl, orally liquid Benadryl at the end of the day, so I don't know. But the other question was...
about the hypoalbuminemia.
Yeah. So that is reported in the phase 3 studies, and it's also reported in other studies. I think this patient population, as we all know, is nutritionally deprived and malnourished, and you add 3-4 therapeutic agents is probably shocking the system and it may not be directly related to zolbetuximab.
Yeah, I agree. I think it's something we've seen with other claudin drugs too. It drops out in the AZD0901 trials and some of the other naked antibodies as well. All right, let's move home. Thanks everybody for staying. We got about 10 minutes left, and I'm going to talk about new drugs and targets to bring us home. So not quite as clinically relevant, but very important. Maybe next year when we're back here, we'll have more to say. All right, so I'm going to talk about TIGIT and PD-1 first, and whether we can approach this TIGIT as a marker with a different approach that's still ongoing, talk a little bit more about claudin, and then talk about ADCs for some other targets. I'll skip this for the instance of time. Very busy on the right, but this is the left, I guess. This is a matrix from RNA sequencing expression looking across various putative immune checkpoints. So you have VISTA, you have TIGIT, you have PD-L1. And what I'm highlighting in blue is if you look at the expression level for PD-L1 and TIGIT, you see that these tend to be expressed in RNA sequencing space overlapping. So high PD-L1 tends to correlate with higher TIGIT expression in RNA space. I'm not going to belabor the point that others have made very well about biomarkers in this disease. This is just sort of the broad prevalences across stage 4 patients. This was the rationale. Like, why did we start to go down this TIGIT story so hard and so many companies go after this? Well, it is an attractive T-cell checkpoint. And there is some preclinical data to suggest that dual blockade of PD-1 and TIGIT does help reverse exhaustion phenotypes and expand this very important population of CD8 T cells, which is called progenitor exhausted. This is the pool of T cells that are probably responsible for anti-tumor T cell responses and clonal expansions of T cells. So approaches that would maximally stimulate this pool is very attractive. And that did seem to be some support preclinically. And a lot of our patients are PD-L1 positive, so perhaps you don't even need to test for TIGIT if there's a lot of overlap in expression, and therefore you could go forward. And there was some support for this. This is just one of the more recent ones, but there's been phase 2 lung cancer support. There was early phase in esophageal. I know you can't read the demographics on the left, but it basically says this is a relatively representative population of gastric and esophageal patients. And this was what's called the EDGE gastric, which was presented at ESMO. And this shows that looks like very encouraging sort of expansion cohort patients. It's limited numbers. So you see, 29 patients with PD-L1 positive, in this case by TAP greater than 1. But if you saw that median PFS of over a year, so that's, approaching the Zani data that was presented earlier, this would get any gastric oncologist excited of PFS approaching over a year, and you see the response rate was related to expression of the biomarker, in this case, PD-L1. So this looked very encouraging, and the survival data actually looked even more encouraging. And what is the blue line is the TAP greater than 1, so there is a influence of the PD-L1 status, just like we've seen from all of the other PD-1 trials. But this was a median survival over 2 years, which Zani is the first trial, as was pointed out, to actually show this in a phase 3 setting in gastric and esophageal. This is a phase 2, but was very encouraging and laid the foundation for the schema along the bottom, which was the STAR 221 trial. So this was a randomized phase 3 trial to validate this observation that dual TIGIT and PD-1 blockade may improve survival, in this case, overall survival and intent to treat in the TAP greater than 5 population. We saw this just a couple weeks ago, about a month ago, December 12th. We saw a press release that, unfortunately, there was no improvement in survival. We did not see a positive phase 3 trial. There does not appear to be any harm, and we will certainly await to see the full data here, but this TIGIT antibody, at least, will not be continuing in the phase 3 setting. That doesn't mean that TIGIT is dead. A lot of various approaches have, I'd say, been undertaken to try to maximize the targeting of TIGIT. In theory, a bispecific PD-L1 TIGIT or PD-1 TIGIT may do this in a more spatially constrained way at the immune synapse, and that perhaps is better. We don't know that. But AstraZeneca is continuing to develop this approach, and you can see there is some, again, support for this from this trial. This is the Gemini gastric, which is a multi-cohort style, sort of laying the foundation for some of these novel combinations. This is the demographics of patients that were included, and so this is rilvegostomig, and unfortunately we're all going to have to learn about MIG and IG antibody end names because there's no longer MAB at all, and so everything is MIG and BIG, etc. But it's a representative patient population, and this was the response rate data. You see that this also looks encouraging. These are very small numbers, but 63%. And then in this upper population, it was 80%. So again, very, very small numbers, a lot of range here, but still support perhaps to continue this in a phase 3 setting. This was the exploratory PFS curves. Again, consistent with what we know about PD-L1 and TIGIT, there is a relationship between PD-L1 strata and outcomes. But again, you see as similar to what was shown in the EDGE gastric, where in this selected population, you see a PFS approaching a year. This is the grade toxicity, just to highlight that there does not appear to be a lot of increased toxicity when we add TIGIT targeting on top of PD-L1. We don't seem to potentiate either or induce synergistic toxicities. So this is going forward, and you can see the phase 3 Artemide Gastric 01 trial here. In this case, it's novel combination, so rilvegostomig and TDXD and capecitabine in the front line. And then to properly assess contributions of components here, there are some additional arms essentially comparing against 811 and Traz chemo, which now we'll have to factor in the Zani data in thinking about all frontline HER2 studies, but still a very interesting combination to go forward. Pivot over to Claudin. This is what was alluded to by John, the distribution of Claudin staining. So at the Zolbi cutoff, about 38% of people in this very large pre-screening effort from the Spotlight and Glow were positive. On the right is a paper that just came out from a visiting researcher that we had at MGH. We looked at what if you went Claudin anything greater than 0, so 1+ or higher in greater than 1% of tumor cells, or equal to 1%. And if you do this, you actually approach about 80% of patients would test positive if you move the biomarker cut point to the absolute floor, which is an H-score of anything more than 0. I want to make the point that Jaffer and John also mentioned about the tails of curves, just to highlight that in the pooled data for Spotlight and Glow, the tail here, the 4-year survival rate, is actually not so different. It's 15% in the Zolbi trials. It's also 15% in Checkmate 649. So there's not a dramatic difference here. There are some long-term durable benefits in the Zolbi-containing arm. There's a lot of interest in pushing on Claudin as a target, and their ADCs are leading the way, and I'm just highlighting a few here on the bottom left by payload, so 2 taxane payloads, 2 topo-1 payloads. AZD0901, the elevation drug has been discontinued, but all the other drugs are in randomized phase 3 trials, 2 in China, 1 global. And John also hinted at a couple of new strategies, which are T-cell engagers and bispecific antibodies, which are shown on the bottom right. Again, this is future-looking, not so much relevant to our practice day-to-day quite yet. This is just to highlight that these are active drugs. This is now called Sony-V, but it is AZD0901, formerly called CMG901. But it is an antibody-drug conjugate against Claudin 18.2. And I want to call your attention to the table at the bottom, which really looks at the Claudin status. So greater than 2+ in 20% of tumor cells. So they're moving the cut point down from zolbetuximab, in theory leveraging Claudin simply as a landing zone for the ADC, and chemotherapy and the payload doing the most of the lifting here. So can we move the payload? Can we move the biomarker cut point down to expand the portion of patients who may be eligible for these therapies? This is an encouraging waterfall plot. Again, these are pre-treated patients, but you see very encouraging response rate data here. So this is going forward in a randomized phase 3 trial that has been accruing and looking like it's accruing quickly. So this is a second-line plus gastric GE junction. Many of you may be participating in this trial, which is randomizing patients initially to 2 doses of the AZD0901, the Claudin ADC, against investigator choice chemo, which you can see the list down at the bottom. It's a long list. And then this primary endpoint here is progression-free survival in all randomized. And then a very smart design, in my opinion, of a dual primary endpoint of looking at overall survival in third-line plus patients. So essentially 2 shots on goal here. And we'll see if we can move these ADCs. A few patients on here will have had prior Zolbi, but that is allowed. These are not drugs that come without any toxicity. This is sort of toxicity from the large phase 1 experience of over 120 patients in the AZD0901. Similar themes that we've seen with other ADCs, fatigue, cytopenias. In this case, we also do see some of the Claudin class effect looking toxicities. So you see nausea, vomiting, and diarrhea, grade 1 and 2. And as Dr. Mehta mentioned, grade 2 diarrhea and grade 2 nausea can be clinically meaningful, even though it's often sort of lumped onto one side, and grade 3 is what's highlighted. Grade 3 is miserable to have grade 3 diarrhea or nausea and vomiting. So it does happen with all of these drugs potentially. To be fair to the other ADCs, they also look quite encouraging. These are 2 others, both in randomized phase 3 trials from Chinese companies, also validating the idea that these are active class of drugs in later line patients who are Claudin positive. This is my last slide, but just to highlight a whole bunch of other targets. I don't have time to talk about some of these PD-1 VEGF bispecifics. Jaffer has done a lot of work on Hippo pathway inhibition, and there are YAP-TEAD and FAK inhibitors. Gilead and B1 have had CCR8 antibodies that look at depleting Tregs in the local tumor microenvironment as a way to try to shift the balance locally toward a more favorable immunotherapy setup. Myeloid cells play a lot of roles in suppressing local T cells, and so myeloid targeting. And then any other surface antigen that you can think of, EGFR, MET, CDH17, etc. Anything you can land a drug on, in theory, you could make an ADC. And then the promise of vaccines, I think, is yet to be realized and certainly a long way off. I do want to end by thanking all of our faculty, John, Jaffer, Rutika. Thank you for taking time. Thank you all for taking time and spending your day here in person and online. Hopefully this was educational, and we'll let you all get back to your evenings.